This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's lexipol.com.
And the fact that MedPAC, this little-known commission, is discarding over half the ambulance services reported data, clearly what they're doing is they're teeing up the rationale for lower or no increases to Medicare ambulance fee schedule rates.
Hello and welcome to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and today we're going to tackle three hugely important issues for our EMS profession, our EMS industry and our EMS world. First up, we're going to talk about the PWW Index, which has been recently published. Second up, we're going to talk about the MedPAC news that our friend Doug Wolfberg so eloquently wrote about in EMS One. And thirdly, we're going to tackle the one big beautiful bill that's sitting out there right now and its effect and consequences on the EMS world. And to help me have that discussion, first of all, I'd like to welcome Matt Zavadsky, returning guest, longtime friend of the show, sole listener perhaps. How are you?
And honestly, I only listen for the entertainment value, Rob, just to be honest.
Well, can I congratulate us on 15 years of stand-up together? So that's it's getting on there. And for those that don't know, Matt and I go back that far, and we have riffed and hit off each other in comedic ways, thanks to my transatlantic nature for all that time. So I'm glad to have you back, and do your best.
All right, Rob. Well, thanks. And we are very excited to release this EMS Financial Index. We all know that EMS agencies are struggling, and the primary struggle is financial, which then dominoes into all of the other issues. So by publishing this index report, our hope is to help use data to drive decision. Rob, that's your favorite four-letter word.
It is indeed.
And quite frankly, then be able to have agencies benchmark themselves and their revenue cycle performance compared to national and regional averages. We think that is hugely important because every day we are asked or get emails from folks asking questions relative to revenue cycle, especially today, even if you're a public agency, a fire department, a private agency, a non-governmental agency, really trying to get a handle on their revenue cycle, especially with things like patient protection laws being passed, potential actions in Congress that we're going to talk about later, the ground ambulance data collection system report that came out. So our hope is that agencies will use this information, and we're going to do it quarterly, to really focus on what are some opportunities to improve the economics of EMS to help drive sustainability.
So, as is traditional for the One-Stop, let's go back and take you back and get some bottom line up front stuff done first of all. So, whose data are you mining in order to produce this report? Where are you getting your numbers from?
Great question. So EMSMC, which is one of the premier EMS revenue cycle management companies in the country and honestly internationally, has data from over 1,500 different agencies across the country. And that is a huge sampling size to be able to not only get some of this national data, but also break it down by region. So that if you're a provider in the Northwest, the Southeast, the Midwest, you can look at what you're doing compared to what your peers are in your region, and perhaps get some best practices to improve your revenue cycle, improve your economic situation.
So that's 1,500 organizations. Clearly that must run into millions of runs.
Millions
and
of
therefore and I can't work out whether it's an M or a B in terms of the millions and billions of potential revenue that's coming through the system.
Yeah, absolutely. Especially from, how much is actually billed, how much is received. But then when we break it down, and in the report, we break down things that would probably be of significant interest for agencies, like what is the average charge in the region, the average charge internationally for an ALS call, a BLS call.
And we'll come on to that. I'm going to cut you off there because
Okay.
otherwise you're going to give me your best answer now, Matthew, and we don't want you to do that just yet.
Okay.
But also, I think it's important to say that this isn't just those privates or the public sector. This is a cross section of the society that is clearly in EMSMC's customer base.
Absolutely. It is
Yeah,
provider type agnostic.
good.
So fire departments, hospital-based, public, private, third service, even volunteer organizations that bill. So it is truly a good snapshot of what's happening in the industry.
Okay, and that's where I wanted to just extract that so we can work out the baseline first of all, of course. Again, data, you've already said it, my favorite four-letter word. Let's actually drill right down into the source code almost to work out that what we're getting is a wholesome and accurate and representative number. And so what you've done is set us up nicely now to say that we are really seeing that. Also, the regional sort of variations, of course, I operate out of California, as you know, others are on the East Coast. The cost of doing business is different no matter where you are because of the economic pressures, because of a number of factors. And so again, to be able to distill that down into regions and of course aggregate it back up into a national number is something that you guys have done.
Yeah, absolutely. And that gives you the opportunity to really benchmark against your regional peers, which is going to be really important. And it also helps you tailor your message. If your state association is going to go to your state legislature and push for Medicaid payment increases, for patient protection balance billing legislation, you really now have some good regional data that you can use to show what, on average, your compatriots are charging in your region, what the reimbursement is in your region for different levels of service. So on a regional level, that helps with legislation and advocacy, but also on a national level, because again, we give that national perspective as well.
So I am going to plug some of the other indexes and of course some of the other charts and graphs because what we're doing here is actually completing almost the trilogy of things that you out there that are either watching or listening can go to. For the news section, of course, Matt and the team produce the PWW advisory notices, and we'll put in the show notes how you can apply for that. Also, if you want to research news items, you can go to emsintel.org, where, again, as Matt talked about there, taking the evidence and taking the story to people that can, all in favor, depending how you say it where you are, can actually make a difference for you. So we have the news tracker that you can actually go through and categorize things in order to tell your story. We talked to our friends at ESO where we talked about clinical indices. Of course, if you want to affect change, we talked about blood. It's EMS week at the time of recording, and today is the day of blood. It's the year of blood, actually.
Year of blood,
so
yeah.
We have clinical indices, and now we have financial indices through this system. So in other words, we are presenting a range of tools, no matter whether you're operational, clinical, or financial, that you can actually use to provide that evidence. The gut reaction that we've always done it this way, the word tradition, which of course is banned, cannot be used anymore when you're trying to affect change. And so this is where you come in, Matt. You come in with the PWW index. So in terms of those data points, then talk us through what you discovered.
Yeah, so some of the aha findings, Rob, and looking through these millions of records, and they're very contemporary. So the first report that you were referring to came out for the first quarter, and it's 2024 data. So it's pretty current. We made sure that we used mature claims so that the actual revenue received had been through the revenue cycle. But one of the first things that became very apparent, and the first aha moment, was the wide variation in charges that EMS agencies are using, and especially regionally. So the Southeast, the average patient charge for an ALS emergency call was $893, but yet in the West, and to your point earlier, the average charge is $2,200. And that just shows differences by region, demographics, maybe political will, but it indicates the fact that there's probably a lot of room for agencies who are not billing at those higher rates to actually do that, which leads into sort of the second aha moment that we had when we were going through this. And we determined with data that, believe it or not, the more you bill, the more you receive. Shocking, but the data actually plays that out. So while agencies in the Southeast only get an average of $405 for that ALS emergency call, In the West, they're getting an average of 713. So this just, again, will show data to say, hey, if we bill more, we're going to be able to collect more, and we'll be able to do things in our agency like perhaps pay people better or get, more equipment or updated equipment, whatever, or reduce the taxpayer burden because we're actually billing a rate that's decent to our costs or close or more closely aligned with our costs, especially given some of the protections that we're seeing now in many states for patient protection regarding balance billing. There's really good case to be made that you should be billing at least as much to be able to collect what your cost of service delivery is. Doug and I did this great webinar with Dr. Mulcahy and others on the ground ambulance data collection report. And really, a lot of these messages are we need to change our thinking on how we're billing for these services.
You make some great points there. And of course, again, this kind of east-west divide, which is sort of what you've just described. Of course, it's the cost of doing business. It's also, and you told me this a long time ago, we could have a paramedic on every street corner. We could have 100%, we don't talk about this anymore, response time requirement. But of course, that costs the earth. And of course, a lot of systems define what they want. And then the organization that's going to do the job has to cost that, has to understand how much it costs to deliver, has to identify the cost of the unit hour in order to deliver that. And then that's how you work out what your costs are. Now, of course, we know that whatever we bill, we never receive. But actually, we also, as you say, if you bill more, you receive more. Now, obviously, I'm talking to a law firm as well, and of course, you bill what you can legitimately bill, and that's the end of that, right? But you need to do that. So, what can organizations do in order to adjust their pricing models?
Yeah, first is understand their costs. And that's one of the things that agencies still really struggle with. And certainly we are willing to help them do that. But determine your cost of service delivery. And if you know that it costs you $2,200 to put an ambulance in front of an address, then for heaven's sake, try and increase your revenue to get much more close to the cost so that if you're getting a tax subsidy, you can perhaps reduce that. And again, if you're a fire agency, great, determine your cost. Convince your city council, your county commission, like Doug has helped people do, like I've helped people do, that increasing your fees doesn't really hurt the patient, but it makes sure that the commercial insurers, which pay more than any other payer group, are reimbursing at a rate that's going to be closer to your cost of service delivery, and that makes a ton of sense. Also, Rob, and you'll appreciate this, we've talked a lot about metrics on this show in the past, and one of the metrics that became pretty apparent that we should no longer be tracking when it comes to revenue cycle and collections is the collection percentage. We still hear people, much like response times, they want to talk about response times. Well, response times don't really matter, except maybe 5% of the call volume. And I would argue that collection percentage doesn't matter either. Because when you look at the report, those systems with the smallest collection rate have the highest dollars collected. And that's the number that you want to worry about. Look at the actual dollars collected for the services provided, not what percentage of what you bill do you get back, because that's sort of a fictitious metric that we should literally just stop using and just look at what's the outcome of the bill, just like what's the outcome of the response. Did we collect more money? We sure did, to help keep the lights on, to reduce tax burden. That's what you should focus on.
And actually, I've certainly been in board meetings in the past where it's, how come the bill hasn't come back in 30 days? The answer, of course, is the situation has changed, or the reimbursement hasn't come back in. The situation has changed. Obviously, we are playing against some of the plans, the high deductible plans, the payouts, all of that sort of tactics you have to play in order to work out when is the most strategic time to actually put the bill in before the hospital, after the hospital, who's scrubbing it for the information. And so actually there's a lot of tactics, which we won't go into today, in order to make sure also that you can maximize the revenue that comes in.
Absolutely right. And there, as you know, Rob, the AIM High Reimbursement Committee just had a couple of great best practice sessions. And in one of those sessions, they talked a lot about that, deductible management. And, we used to worry about how long is it going to take to get the bill out? We want to do the call today, send the bill tomorrow. No, that might not be the best strategy. So the indexes like this and the subsequent ones that are going to be coming out quarterly will help agencies make those decisions with actual data, and it's going to be great.
So, for those listening out there going, oh, here they go again, banging on about the money. Well, let me tell you something, everybody. The EMS is a business, like it or not, whether you're in the private sector, whether you're in the public sector, even not for profit doesn't mean all for free. You have to pay people, you have to buy the supplies. How much does an ambulance cost these days? How long does it take to get that ambulance that you can't afford? So, there is a whole range of costs that go with that. And spoiler alert, even the public sector folk are billing for service. So it's not one of those free goods. It's something that we all have to pay attention to, whether you're in the corner office or indeed on the truck. It all matters. ALS versus BLS, you spend a lot of time going into that. And of course, how do we, and many people may know this, but again, I'm trying to just do an explainer here. How do we determine which is which?
Yeah, and the great way to do that, and one of the reasons this index is so valuable, is it's how the call was billed. So if the response warrants and permits an ALS reimbursement because an ALS type of call, an ALS crew responded, ALS assessment was done, those things typically allow for an ALS bill and an ALS reimbursement. Now, the ALS care in the back of the truck might not have actually been a needle in the arm or a drug administered, whatever the case might be. But in this first report, we've looked at what percentage of the calls are billed at the advanced life support level or at the basic life support level or the SCT level, et cetera. And you can see, quite frankly, some of the wide regional variations as it results to that as well. But to answer an age-old question, keep an eye out for quarter two's report. We're going to take just the emergency responses from all of those millions of calls and figure out and give to the industry what percentage of the emergency calls had ALS care billed versus BLS care billed. And it's going to be, I think, pretty interesting, especially in some regional variations to see, but much like the Medicare GADS report, this report is aggregate, right? So it's all calls, including emergency, non-emergency, but broken down now at the request of some of the folks that sent in comments, doing it just from the emergency calls. Gosh, only 50%, maybe only 40% are being billed at the emergency level. That really speaks to maybe tiered deployment isn't such a bad thing because that's what we're doing already.
Absolutely. And obviously, one of the things, and you just really triggered a supplementary question there, of course, is that organizations, I think, should have an audit by, let's call it the friendly forces, to come in and actually look at your billing strategy, to look at actually what you are billing out and work out if you can, let's say safely increase the bill within the rules, the regulations, and the climate.
Yeah, absolutely right, Bob. And also in the next report, because we've asked this question or had this question asked quite a bit, is billing for treatment in place. Some agencies have fully embraced that and are billing for treatment in place without transport. So a lot of agencies are like, well, Medicare doesn't cover it, so they're not going to bill it. No. Here, for those agencies that are billing for treatment, no transport, here's what they're getting reimbursed. And why, when you're struggling financially, why are you not trying to maximize your revenue so that you can pay people better, so you can reduce tax burden, et cetera, by paying for the services that you're providing? Or billing for the services that you're providing. So this will give that insight into the industry and hopefully drive a lot of change.
So here's another angle. Of course, when somebody calls 911, we don't ask for their insurance details. We don't understand if they are with a certain insurance provider. Yet when we come on to the back end, of course, there is well, you weren't in plan and all these kind of, things we sometimes see on the news. So how can we work better with insurers?
Yeah, absolutely. And that is getting to those insurers and making the value case. When I was at MedStar, we did this. A number of agencies that are doing it very well across the country. EMSMC has had us help them with some of their conversations with payers to convince payers to pay for things that are going to bring them more value. Paying for things like non-transport treatment in place, maybe paying for community paramedicine and mobile integrated healthcare. You can use this kind of data to say, by Blue Cross Blue Shield, Anthem, Cigna, United, whatever, you're paying us $1,200 to take this person to the emergency room, and you're paying $4,000 to the emergency room. Your member isn't very happy because they waited for 12 hours to be seen in the emergency room. Maybe there's a better way for us to service your members that keeps us financially whole, but makes your members happy, and most importantly, saves you a boatload of money. And this type of data will help agencies do that.
So before we go to the break, Matt, are there any other of those sort of key metrics that you want to just sort of run us through?
No, we just picked those five when we first
Yeah.
started. The one that we're doing coming up is going to be a little bit. It's going to have another summary of those
Okay.
five. How much is being billed, how much collected with service mix, etc. But we're going to do a little bit of a drill down into things like Medicare Advantage. I just finished looking at some of the data last night, and I think everybody's going to be a little bit surprised at how much less Medicare Advantage is paying EMS as opposed to regular fee for service Medicare. And what does that mean for us as more and more people go into managed care plans through Medicare Advantage? So, and how do we attack that? Either regulatorily, statutorily, or in relations with the payer. So again, our hope is that this will help improve the overall economic sustainability of the EMS systems across the country.
So we are in an economic battle. We have to sustain in order to survive, in order to serve. That's pretty much where we are in a nutshell. So, as I said at the start, one of the reasons for this podcast is to discuss what we're doing, and that's what Matt's just described. We're going to go on to talk about what they think, and then we're going to finish off by talking about what they possibly could do to us. So, let's come back after the break.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
And we're back. As always, please make sure that you like and subscribe wherever you get your podcast or your vodcast. Remember, we're not only on Apple Podcasts or any other podcast platform, we're also on YouTube, so you can listen to us, or you can listen to us and see us. And every time I say this as well, that don't forget that if you're watching on YouTube, we insert slides, charts, graphs, graphics in there to give you the webinar you didn't know you needed. There we go. So that's what we're doing over on YouTube. If you're listening to us, pop over, like, subscribe, and give us a rating. We love that. So we're talking about a number of important financial issues. We talked about the PWW index with Matt before the break. I'd like to welcome Doug Wolfberg. And Doug, I think I see you on a Zoom at least once a day now. It's becoming very, very regular. And thank you for doing what you're doing for the industry. It's much appreciated. Your guidance and counsel is superb. But you've written a stellar article in EMS One talking about MedPAC. So A, welcome, and B, tell us all about it.
A, thank you, Rob. Great to see you again. And B, I will do just that. So,
Thank you.
yeah, so what we're trying to shine a light on here is that Medicare, CMS did this ground ambulance data collection system where they collected really for the first time universal from all ambulance services in all corners of all different types across the country. There were earlier government studies about ambulance costs, but they only looked at certain types of providers. So this was really a golden opportunity to really show policymakers, Congress, state legislatures, insurers, and others that the amounts they're reimbursing us don't cover our costs, right? The CMS data clearly show that. Great. Well, because of federal law, this report goes next to an agency, a commission called MedPAC, Medicare Payment Advisory Commission. And this is not an organization or an entity that a lot of folks are familiar with because it's not part of our everyday vocabulary. We talk about CMS and Congress and state Medicaid. MedPAC is the commission that actually makes recommendations to Congress on Medicare payment policy, including amounts for coverage of things like ambulance services. So when MedPAC took up this report at their meeting at the end in early March, all eyes were kind of on what MedPAC would do with this data because the CMS data very clearly showed that reimbursement amounts do not cover costs for ambulance service. So having that clear data, making that clear case to MedPAC, a lot of folks thought this is great. MedPAC will have no choice but to look at this data and say Medicare has to increase rates to keep pace with ambulance service costs because they're not sustainable. Would you like to guess what this MedPAC commission did with the CMS data, Rob?
I would not only like to guess, but also I can show you the slide that they put up in their presentation, but I'll save the spoiler for you, Doug.
Okay, well, MedPAC, which I said is the arm of this bipartisan congressional commission that advises Congress on Medicare payment policy, composed of 17 commissioners and then a staff. It is billed as a nonpartisan advisory body commission. They took the CMS data and they actually threw out the ambulance services that had high costs, right? So when this CMS
and can
data,
I say, see part 1 of this podcast?
Yeah,
Right.
when you see, the CMS data saying that costs are high and reimbursement doesn't keep pace, MedPAC said, we'll just throw out the ambulance services that have high costs. Well, what ambulance services have high costs? Rural ambulance services, because when you have fewer call volume, lower call volume to spread your costs among, your cost per transport is going to be much higher. And government-based, right? So fire-based and municipal third service agencies generally have higher costs because overhead, benefits, et cetera, compensation is generally higher. But that's an enormous part of EMS in the United States, right? So MedPAC actually discarded over 50% of the ambulance service costs that were reported in the CMS data. Let me say that again. MedPAC actually threw out from its cost analysis more than half of the ambulance service cost data in the United States. So if they're trying to, sorry, go ahead, Rob.
No, I was just having one of those whiskey tango foxtrot moments there, first of all. and so they threw out the majority. Now, under normal election rules, the majority wins, right? But not in this case.
Yeah, definitely not. So, more than 50% of the ambulance services, how can they be the outliers, right? And what MedPAC's argument is, or their rationale for discarding that data is the term shared cost centers, right? So what they're really saying is we don't trust ambulance services that have that are parts of entities that do other things. So if you're part of a local government, you have a street department, a parks department, tax collectors, right? They're saying we don't really trust ambulance services to break out the costs of actually providing ambulance service because we think there are too many other, costs that might be buried in those figures. So there's this aversion to ambulance services that are part of other entities like hospitals are, local governments are. And they say rural ambulance providers are those are outliers because they're too high of cost. Well, I have news for you. In certain settings, it does cost more to provide ambulance services. That's an inescapable, unavoidable fact of life. And the fact that MedPAC, this little known commission, is discarding over half the ambulance services reported data, clearly what they're doing is they're teeing up the rationale for lower or no increases to Medicare ambulance fee schedule rates, because they're saying those are outlier costs. So there's no case to be made to substantially increase or increase at all the Medicare ambulance fee schedule rates. They're using that as cover to no doubt suppress the amount of increases, if any, that they will recommend that Congress make to ambulance funding under the fee schedule.
So we spent a lot of time agonizing over getting the data right, over organizations putting the data into various systems that eventually went into the sort of central database. And so if I can bumper sticker eyes for a second, Doug, so actually we had quality in, but what we're seeing is garbage out.
Yes, that's exactly right. When you manipulate the data to get the story you want, you'll get this argument for less cost increase or less fee schedule increases. And that's what MedPAC is doing. And to your point, Rob, about how much ambulance services across the country agonized over the collection and the reporting of this ground ambulance data collection system reports. it's a slap in the face to ambulance services across the country that did thoughtfully respond to these data surveys and report their ambulance cost data diligently and spent the time and effort and capital to do that. To have more than half of that simply thrown out because MedPAC is afraid that that will support higher rate increases for the Medicare ambulance fee schedule, and they want to keep those increases to a minimum, that it is a slap in the face to the industry and to every ambulance service that took the time and spent the capital to collect and report this data.
So those few good men and women told us essentially we can't handle the truth. Work out that line if you dare.
That's exactly right. You can't handle the truth, so we're not going to show you the truth. They cherry-picked the lower cost providers within the industry, which are primarily private for-profit and in some cases private nonprofit, who have to be efficient because they can't just levy taxes and collect tax revenue and get subsidies, right? So they have to subsist on the revenue that they generate for their services. So yeah, by definition, those types of agencies will have lower costs. And then MedPAC is using that as the circular argument for why we don't need a raise. But those companies have pressures. We have to invest in new equipment. We have to pay our people living wages. We can't use EMS as a stepping stone to other careers where people come in and then get out. We can't develop career pathways without proper compensation. So it's the opposite of a virtuous cycle, right? It's a cycle of insufficiency and unsustainability that MedPAC is using this cherry-picked CMS data to produce.
A cycle of unsustainability. That sounds like one of your quotes from a presentation you can possibly do in the future, Doug. I know.
Yeah, I just came up with that too.
Yeah, it could be another Big Bang Theory episode coming up, except the Big Bang is on us by the sounds of it. So here comes the A-B question, right? So A, they have written the report, they have prepared and delivered the slide deck, the results have been promulgated. What are they going to do next? And B, more importantly, because of A, what can we do next?
Good question. So for A, I think what MedPAC will do next is go forward to Congress, issue a report and say, with the data we looked at, the data we chose to use, we think Medicare rates are basically sufficient or possibly with a small increase. That's what they're teeing up, right? When you throw out the high cost data, you're teeing up the rationale that we just don't need that much of an increase. So I think that's what MedPAC will do. What can we do? As you said, this is our Whiskey Tango Foxtrot moment, which is absolutely awesome. Most EMS folks get exactly what you mean. But I would say we also have to throw the BS flag, right? And I think we have to call out this government overreach and this government ignorance of reality, willful ignorance of reality. We're choosing not to look at reality so we can produce the result we want. That's why I wrote this article in EMS One that, as you know, is being also run in other state association publications to shine this light, because this is not an entity that most folks are familiar with, yet it is an entity that is going to, in large part, recommend our fate. And I think what's important is to remember MedPAC is an advisory commission. We can still and we must communicate with our members of Congress. And this is where state and national associations, membership associations, are so valuable, because they push out the information on how to contact your legislator and what kind of things to say. But we need to reach out to our own elected officials in our state, congressional, and senatorial delegations and tell them that what MedPAC is feeding them is wrong, it's incomplete, and it paints an inaccurate picture, and that we need substantial relief under Medicare payment rates and the Medicare fee schedule, and that MedPAC is misinforming Congress, and that Congress can still act on their own. They don't have to do what MedPAC tells them or advises them to do. These elected officials are independent, and they can raise their hand and vote whichever way their conscience suits them. We have to give our elected officials the information so that they can read these MedPAC reports as discerning, critical consumers and know that what they're being told by this supposedly neutral bipartisan commission is wrong and it sells our industry short. And I would say the last thing that we can do is use the CMS cost data report, which paints a very clear picture of an industry in distress. And we don't have to use the MedPAC cherry pick data. Use the CMS GADCS report to go to state Medicaid policymakers, state legislatures, insurers, and others, and advocate with that data for higher rates at the state level and through commercial payers. So I think those are the things that we can do to operationalize our own action plan.
Thank you. That was an amazing call to action. That was the soundbite that I needed, and I will pass on to others as to do. And again, to summarize, Bravo Sierra, Whiskey Tango Foxtrot. We're going to get through the entire phonetic alphabet by the time we finish, but thank you very much for that masterful assessment. Before we move on to sort of part three, as in what they're going to do next, any sort of final thoughts or any additional calls to action on the MedPAC stuff?
No, but I would absolutely echo the closing message that my colleague Matt Zavadsky had, which was, while we're waiting for payers to do the right thing, which is like, moving a mountain in some cases, we have the responsibility to take sustainability of our profession and of our agencies into our own hands. And the things that Matt has been talking about and leading our industry on for years with his clarion call to redeploy and change the ways we do business. One of the reasons Matt was such a great fit here at PWW is that those are things that we advocate and that we integrate into our consulting work, system design work, a lot of the work that we do on system assessments and design. We have to deploy modalities that are more cost effective because the vast majority of patients do not require time-sensitive, critical, life-saving interventions, and many are low acuity. And our biggest cost is the cost of preparedness and response. And when we can change the way we do that and cue these calls in a way that makes clinical sense and follows the data, we can take a lot of the costs of deployment into our own hands and enhance our own sustainability. So we have to follow the evidence to sustainability. And that's really what we can do while we're waiting for payers to come around.
Excellent. Thank you for that. And as I've always said, that if we do what we always did, we'll get what we always got. And obviously you're encouraging us to move on, move up and embrace the opportunity to change right now. Let's go into part three and also bring Matt back in. So we are seeing politically right now, one big, beautiful bill is out there. But the implications of the one big, beautiful bill for us, is it so beautiful, Matt?
Not at all. It's going to be quite challenging. And really the four things that was called out in some of the payer publications are of acute interest. It should be of acute interest to EMS agencies. First, this bill reduces the number of eligible Medicaid beneficiaries through work requirements and some other things and limiting eligibility. So imagine if a large percentage of your Medicaid patients are no longer covered by Medicaid and they fall into the self-pay arena. That's going to be real challenging. Second, and for those of us that have been talking a lot about this GEMT and state-directed payments and provider tax and all the things we've been talking about, is it bars states from using direct state-directed payments to require Medicaid HMOs, which are the majority of the Medicaid payers in our country, to pay more than the Medicare allowable. So imagine in California, Rob, which is where a lot of these programs are, that are getting over $1,000 for a Medicaid transport, that gets dialed back to the Medicare allowable in California. At the very least, I mean, that's before the audits are done and etc.
So just again, Matt, take us back 1 second. So explain how the feds are matching reimbursement. So I'm California, you're the Fed. What are you giving me?
Yeah, so it depends. It's state by state based on the federal matching program, but generally it's about a 60-40, 70-30. So if the of $1,000 reimbursement, if you will, roughly 600 will come from the feds, 400 will come from the state. But again, that varies dramatically. If you're in Mississippi, it's way different than if you're in Oregon. But the reality is that regardless, in order to be eligible for the federal match under these programs currently in this bill, which is on a freight train going through Congress right now, is that the most that a state can reimburse under these types of programs is what Medicare would have normally paid for that same level of service. That's huge, especially for these areas like Illinois, where providers are getting reimbursed $2,200 for a Medicaid transport. Now they go to the Medicare allowable, which I think in Illinois is about $360. Changes everything. It also adds a cost-sharing component to Medicaid, much like Medicare already has. We've never had a cost, to my knowledge, and Rob, you're much older than I, so maybe you know, but we've never had
You lie like a cheap
copay,
Matt.
$35 copay for Medicaid. And I didn't even see this in the bill, but a friend of mine who's the president of the Dallas-Fort Worth Hospital Council said it also freezes the current programs. There can be no increases for any of these provider reimbursement or provider tax programs. So that's a huge issue on the whole Medicare side or Medicaid side.
We adjust our lifestyle to match our income. So if you're an organization that is enjoying a very high reimbursement rate because the feds are actually paying more than the state in some cases, what are the consequences if the rug gets pulled out?
It's huge, and it goes back to what Doug said. We really need to look at the cost of service delivery and what does the public expect. The public expects a certain delivery level now because they have to pay this much for that because Medicaid is paying this much. If suddenly Medicaid is going to pay very little of that, the question becomes for the local community, okay, we're not getting reimbursed the same way anymore, so you're going to need to pony up $1 million, $5 million, whatever it is, to keep the same service level. How important is that to you? And is it important enough to write a $5 million check? It's going to be some tough conversations. Doug, would you agree?
Yeah, I would say that, at this point, there's going to be a reckoning that if local, municipalities want the same level of service that they've been sort of accustomed to, they can have it, but they're going to have to pay for it. And that means they're going to have to make a case to the taxpayers, right? This is the level of service that we provide. And, now that the reimbursement is being reduced drastically, they're going to go to their hat in their hands with their taxpayers. Now, the taxpayers, I think, have largely in many communities been sold on more, right? More bodies, more trucks, more stations, or grandmothers and babies will die, right? And in large part, those narratives have been pushed by our own profession, right? And in many cases, the agenda there is to generate more hiring, more union members, which perfectly understandable. That's their agenda. There's nothing wrong with that. But when you base that more on a predictable level of reimbursement that suddenly gets dropped drastically, if you want to keep more, fine, but you're going to have to pay for more. Now, when you go to your taxpayers and say, well, we need now this amount of tax support to support this level that we've customarily provided, that's when people start scratching their heads and saying, wait a second, do we need all this apparatus and all this people for a sprained ankle call? So when your deployment and your services are built around more, and the evidence and the data clearly show that you don't need that degree of more, right? One BLS ambulance getting there when they get there will probably do the job, and the bodies will not be stacked at City Hall, right? Like cordwood, as Matt and I both use that phrase a lot. So if you're going to ask your taxpayers to support the services that they're accustomed to, and you can't make the case that you're doing that effectively and efficiently, but all you're doing is scaring them to say, if we don't have more bodies, more trucks, more stations, more of this and more of that, people will die, you've misserved your communities. And I think that's the reckoning that's coming, where local elected officials really also need to look critically at the levels of and types of service they're providing and ask themselves, is that sustainable? Yes, in the past, private companies, nonprofits have had to worry about sustainability. Public sector ones, not as much because they have the tax base. Well, guess what? When sustainability comes from tax revenues and the taxpayers are asking those questions and you don't have the data-driven answers, that same reckoning is going to come to public sector providers as well. So I think that's the next step where elected officials really have to look hard at the types of services they're providing and ask themselves, are they optimized? Are their deployment strategies sustainable? Is it evidence-based? And are they doing right by their taxpayers?
I'll put an exclamation point on that. We just finished a project in a mid-Atlantic state, and literally in the county commission meeting, very well-respected county public agency said, yep, if you want this level of service, we can verify it's a $5.6 million subsidy that they're going to need. And one of the county commission members said, what can we get for $1 million? Right. It's just,
it comes back to that point that you made years ago, Matt, that, you can have 100% response time. You can have a paramedic on every corner. You just got to have a big fat checkbook. And right now we're about to actually be repossessed by the bank. Indeed. So listen, so you have been talking about this, Matt, for a long time. And, there has been the occasional, oh, here he goes again. But actually, this is coming to fruition, and I made the Sierra Stormers are coming, to use another abbreviation. So people need to be prepared. We need to batten down the financial hatches, or we need to actually start briefing as to the impact this potentially could have. And I know that you've done that in a number of presentations. Obviously, with my California hat on, you gave a masterful session yesterday to a state that's probably going to be whacked by this storm the most. This is going to be force 10 in California, let me tell you. But what should others be doing, just sort of finally, and to recap?
Yeah, start looking at your book, start having a conversation with your local officials. Nobody likes surprises, especially elected officials and their appointees. So city managers, county managers, start those conversations early. One of the things we haven't even talked about is the Medicare side. So in addition to all the Medicaid stuff, one of the things that happens if this bill passes, and I'm not a betting man, but I'm going to bet that this bill passes pretty much the way it looks right now when it gets through the Senate, is the PAYGO. Remember PAYGO? We talked about for a long time. This bill will trigger those PAYGO cuts. And now your probably largest payer is going to be mandated to reduce reimbursement to you because of the spending that this bill requires. So on all sides, we're being compressed. So having those conversations, looking at your system, getting with your medical directors to say, hey, if we do what people have been talking about, use the evidence to change how we deliver service, how much money would we save? What is the financial impact? Can we improve some service levels over here for the high acuity calls while right sizing the resources that we're sending to the lower acuity calls? Start educating your public. Many places in Iowa and others that have done essential service designations have run campaigns to say, hey, we need funding, we need a levy. Ohio just did this. And if you educate your community, most of the time, you will find that people are willing to step up and help cover some funding gaps depending on the level that they want. But you can't do it last minute and you can't do it willy-nilly. Start planning that literally today.
So another call to action from Matt. This storm is a-coming. Watch the politics, talk to your politicians, brief your public, ensure they all understand what's at stake, what you deliver, and as Matt always talks about, the value proposition of the thing that you're delivering to them. So before we go, you've heard me ask this question before. Anything I've forgotten to ask? Anything you need to tell us, Doug?
Yeah, just to dovetail on what Matt said, I think there's some real political experts out there in our industry, folks that you should follow on social media and listen to what they say. The AAA has very good legislative antenna, as Belmonte's. There's others, in the industry who are really dialed in. But my read is that there are some senators who are, you would expect to be cut budgets, reduce benefits, who are actually coming out and saying, wait a second, these deep Medicaid cuts could be devastating to our healthcare systems in especially poorer, more rural states. So there are some surprising voices out there on the Senate side who are advocating, hold on here about these Medicaid cuts. I think Matt's right. I think it is likely to get sort of steamrolled through on this track that it's on. But I think there are enough voices of concern in the Senate, even from quarters we wouldn't normally expect that contacting your senators and really strongly making the case, and quite honestly, especially if you're in a red state, because the blue state delegations generally don't want to reduce the benefits and the budget amounts by that much. The red states is where the pressure to cut, again, not being political, just being factual here. And for those of you who are watching and listening in those states, contacting your senators in those states, because it is some of those who are expressing those concerns, you can help sort of push them to do the right thing and not make draconian cuts, where it could really have a devastating effect on access to care. And the last thing I'll just note, and I'm sorry I keep going on here, we got to remember when hospitals get hit and other parts of the healthcare system, we become the safety net, right? When folks don't have access to primary care, for example, when benefits are reduced, they're going to go to emergency rooms because whether you're a citizen or not a citizen, hospitals have a legal duty under EMTALA to do medical screening examinations and provide stabilizing care. A lot of them are going to get there with EMS. So it's hospital emergency departments and EMS that are going to bear a disproportionate share of this utilization, much of which is not going to be reimbursed or not going to be reimbursed at adequate levels. So this is very impactful to EMS. And I think there's an opportunity, at least as of the date we're recording this, when this bill passed by the House goes over to the Senate, that's really the best opportunity to put some pressure on those senators.
Great. Matt, final thoughts?
Nope, just echo what Doug said.
Excellent. Thank you. Well, this has been really informative. We've tackled 3 vitally important issues of the day, of the week, of the month, potentially of the future. And so thank you for helping me do that. We've discussed what we're up to with the index. We've discussed what they think we're up to with the MedPAC. And of course, we've talked about that bill that could actually change everything financially, operationally, livelihood-wise for a lot of people. So Doug and Matt, Bravo Zulu, thank you very much for joining me today, and I hope to have you back on real soon.
Thanks, Rob.
Thank you, Rob.
So that was a complex discussion. So if you are a state EMS director, if you are a member of the administration that deals with it, if you're a locally elected official, if you're any of those things, show this podcast to each other. If you're listening to us in the corner office or on the truck, there's a lot at stake and a lot to play for right now. So pay attention to what's being said here, please. In the show notes, all of the references, all of the documents that we've talked about are in there. So have a look at those. Read Doug's article on MedPAC. It's also attached to the show notes. All of this stuff. If you're in a state or a national association, we know you're acting, we know you're looking, and we know that you are taking action. So please keep doing what you're doing as well. So huge broadcast today, really important topics. And so that was another edition of the EMS One-Stop podcast. Please make sure you like and subscribe. Thanks to Matt and Doug. I know they'll be back. I've been Rob Lawrence, and until next time, bye for now.